Thank you so much for joining us today. I want to welcome everyone to the STS 2024 webinar series. Today's webinar is titled Robotic Bronchoscopy, Managing Sub-Centimeter Lung Cancer Tumors Together. Please note this webinar is being recorded and will be available next week on the STS website and STS YouTube channel. We invite you to become a member of STS. If you're not one already, you'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership or scan the QR code on your screen. At this time, I'm pleased to introduce our STS moderators for this evening, Drs. Lazar and Rickman. Dr. Lazar, welcome. Let me turn it over to you.
Good evening. My name is Dr. John Lazar, and I'm a member of the STS, and it gives me great pleasure to introduce my partner and co-moderator, Dr. Otis Rickman, also from Ascension St. Thomas and the University of Tennessee at Nashville. The topic today is sub-centimeter lung cancer tumors and managing them together. The significance of the word together is the idea that thoracic surgeons will be working together with their partners in interventional pulmonology. And we've got a great bunch of panelists tonight, which we hope to discuss our topics tonight. Otis, do you want to say a couple words?
Absolutely. So thank you, John, for inviting me to be a co-moderator with you. And thank you to the STS for putting this together. I think it's a very important topic and something that, very much a synergy between thoracic surgery and interventional pulmonology as we sort of move into these small little bitty nodules. And I would like to, the first person on our program is Dr. Ali Jawani. Ali, if you want to go ahead and come on screen there. Dr. Jawani is a board certified interventional pulmonologist at Orlando Regional, a member of the Thoracic Institute there, and partners in the thoracic surgery program. And he's the director of interventional pulmonology and is a whiz with the robotic bronchoscope. And so I always learn something every time that I visit him. And so he will be talking to us tonight about the advanced bronchoscopy and the robotic platforms that are out there. Ali?
Well, thank you, Otis. It's very kind of you. And thank you, Otis and John, for both having me on tonight. I appreciate that. Give me a second to share my screen. Okay, so we're going to talk about diagnosis of advanced bronchoscopy, specifically the robotic platforms out there. Just some quick disclosures. I do have some consulting fees honorary from Tube Surgical, Siemens, and I am a member of the Biodesics Pulmonary Advisory Board. Let's talk about the case for robotics. We kind of know what these are, but just to reiterate, the idea was that we need something better than the scopes we've had today. We need stability of that catheter, that scope. We want that ability to navigate to smaller subsegments, to get out to that outer 1/3 of the lung reliably. We want the ability to have accuracy when you're getting out there, and we need to prep for the future, right? We know therapeutics are coming, and we're going to hear a great talk about that in a little bit tonight. But in order to get there, we need a platform that's going to allow us to get there stably and reliably. And we know that electromagnetic navigation, which is what we've had traditionally with our flexible bronchoscopes, the diagnostic yields have not been as where we'd want them to be. And in the largest trial to date, the Navigate trial, was kind of disappointing overall at demonstrating what those yields were. And frankly, we also need to make sure that we can compete and to decrease the complication rates when we compare ourselves to the gold standard or TTNA. Let's talk about the tail of the 3 robotic systems that are out there commercially today in the United States. In 2018, we had the first system come to market. It was named the Monarch by Ethicon, or at that time it was by Auris. It's an E&M-based system with robotic assisted bronchoscopy. A year later, the Ion by Intuitive came out, which is a SAPE sensing based technology for robotic bronchoscopy. And finally, last year, the Galaxy by NOAA came out, which is also an E&M-based system for robotics, but it combines integrated digital tomosynthesis. So let's talk about the differences and similarities between these systems. Yes, they're all robotic, but I think that the differences are quite striking. When it comes to the original system, released in 2018, it's a pure electromagnetic. It was mirroring the idea that you now had a rigid scope of some sort that you could guide with the E&M-based system. It worked on an outer sheath with an inner scope type of idea, a 6 mm outer sheath, a 4.2 mm inner scope, had a working channel 2.1, and it also had continuous vision. So it was very much kind of like replacing what scopes we use today. The scope was reprocessable, though in theory it actually never worked. There was no integrated device imaging with this system. The system that was released in 2019 was based on shape sensing technology using fiber optics. Its catheter was smaller, 3.5 mm. Its working channel was a little bit smaller, appreciably the same at 2 mm, but it had no continuous vision. The vision probe became removable. This was also something that had to be reprocessed per reuse and had integrated cone beam workflows that we'll talk about a little bit later. And finally, the system released in the last year is also electromagnetic, but like we mentioned before, integrates digital tomosynthesis. The catheter size is about 4.0, so splitting the difference between the two other systems. The working channel is 2.1, but it does come with continuous vision. The scope is disposable in this system, so there's no reprocessing to be thought of. It does integrate 2D fluoroscopy, and we're going to talk a little further about what that means. So let's go a little bit into the three systems and talk about the kind of the pros and cons, right? So for the first system that came to market, it was a fairly large system, all things considered. You had a tower and a robotic cart, both very large and bulky items. There's an electromagnetic generator that was unfortunately positioned to the side of a patient. And then there was a video game style controller. So it had many drawbacks, as one can imagine, for a first generation system. It was extremely sensitive to interference. The C-arm alone, when we would bring it in, could cause the ball to jump all over the place. It would not necessarily get where you want to go. You had, if you wanted to do bilateral lesions, you had to move the generator from one side of the body to the other side of the body and re-register all over again. Due to the larger size of the scope, even though the articulating part was thinner, the larger diameter of that meant that it could not necessarily get to all parts of the lung. So there were some limitations of where you could reach. Setup time was considerable for this system, and it was very important that you could line everything up in a very particular manner, and if you didn't, it would not work. And there was some issues where, depending on how you were adjusting the catheter, there was significant lag time between the time you adjusted it and the actual responsiveness of the system. Shape sensing technology, when it came on the market a year later, basically brought a new idea to the marketplace. Shape sensing technology has been around for many, many years, but it's not been used in medicine until now. So they took an idea of an ultra-thin bronchoscope at 3.5 mm and used these fiber optic fibers to figure out where that scope was in 3D space at all times. It has now one large tower, or an integrated robotic tower, where everything sits on it, from the monitors to the actual arm coming off. The controller, instead of being gamepad based, is a mounted controller, so it's always there, standing there at the ready. This one, because there's no E&M fields, it didn't have those drawbacks, no generators, no sensors, no interference. And so if you wanted to basically do bilateral lesions, you didn't have to re-register. You could bring the scope out of the body and put it back in, and there was no need for re-registration, cutting down on time and complexity. Now, the shape sensing technology also changed the conversation on divergence, so we're going to come back to that in a little bit. Setup for this is relatively quick, breakdown is even quicker. And it had its own proprietary navigation planning software that was different than the other E&Ms, which we'll come back to as well. Now, some major drawbacks. There's no vision during bronchoscopy, and you have to be able to reprocess the parts. Finally, the third system that came to market recently, which included digital tomosynthesis. So combining robotic E&M again with digital tomosynthesis. One very large part, it has the integrated robotic tower, sits at the bedside. It uses the video game style controller that was similar to the original system released. But recognizing that E&M has localization limitations, it allows you to use any 2D C-arm that you have, no matter the age, and integrate that into a digital tomosynthesis platform. It also has a version of augmented fluoroscopy built in. So as you're biopsying, you have an idea of where you're supposed to be. It does have some drawbacks. It is still fundamentally an E&M system. So using the digital tomosynthesis is absolutely required. You can't just use the system on its own and expect that it's going to be accurate every time. Now, I wanted to point out that one of the things that's underappreciated is the E&M, basically the shape sensing technologies. There's a huge difference in the software that allows you to plan. And that has to do a lot with where historically the software is based out of. E&M based technologies are all based from the same mother company that owns the rights to this technology. So that's why all the software underlying it is very similar. But what's interesting is the shape sensing based technology came with the software that was written from scratch and is not reliant on that same technology. And as a result, they were able to come up with algorithms to do much deeper segmentation. What I'd like to call your attention to briefly is this is actually the same patient, the same CT loaded into both planning laptops on the same day. And I want to call your attention to this bronchial tree. You can see how many segments this thing is segmented out to, yet you can see how many segments this is segmented out to, okay? So the shape sensing technology provides much deeper segmentation, which allows it to do its job later on. And we'll talk about its effect in a moment. And that comes to divergence. So divergence exists with all systems, right? We recognize the idea of the CT to body divergence, meaning we know that the CT, when we obtain it, and the way the patient's breathing at the time that we're actually doing the bronchoscopy is going to be different. That affects every system irregardless. It affects all of us, no matter what CT protocol we use, no matter what anesthesia protocol we use. Where there's some basic differences is in the electromagnetic-based technologies. We know that they use reference points. If you've ever had to hear about manual registration, do manual registration, we use certain carinas from the main carina, the right upper lobe carina, left main carina, and sometimes the right lower lobe carina to be able to define the reference points. With the first generation system, you're basically using those sensors around the body to then guess where your lesion is between, make an educated guess of where your lesion is in between that reference point and the sensor. And then you're using your chip track catheter to figure out where the catheter is in reference to that. But once again, that's an educated guess because we know that we're not necessarily breathing the same way. The DT-based platform, the digital tomosynthesis-based platform, recognizes this and corrects for this out of the box using a standard 2D C-arm by doing this digital tomosynthesis. Now, the shape sensing technology-based platform uses a different idea. So using that very detailed bronchial tree, the reference point no longer becomes the main carina or right upper lobe carina, it becomes the exit point of the bronchus itself. So in theory, if you think about that, that decreases the amount and degree of divergence, because instead of a divergence being from your right upper lobe carina to the lesion all the way out here, your divergence potential becomes from that distal bronchus to the lesion, which means it may be a lot smaller. It doesn't do away with divergence. I think that's an important point to make, but it does help to minimize that divergence. The shape sensing technologies have also been useful in the sense that they have integration with the GE 3D C-arm that's been newly released this summer, and they've had integration with the Siemens 3D C-arm that's been released in summer of 2022, aka mobile cone beam that allows for correct for any of this divergence that is noted. Flipping topics for just a second, we'll talk briefly about one of the tools that's kind of been hot topics and to use today, and that's cryo probes and cryo biopsies. We see it as a very simple way to overcome suboptimal pathology, suboptimal sampling. Sometimes we have no choice, right? We are only able, and that's the first picture is a picture of a cryoprobe. The second picture is a picture of how this cryoprobe could be useful. For instance, if you're only able to get an eccentric view or be next to your lesion, using that cryoprobe, which is in red, it freezes around it, and you can rip a piece of that tumor right off. So you do not have to have tool truly in lesion in order to get a sample. And here's some representative examples of what these cryobiopsies could look like. Now, granted, these came from a slightly larger probe, but we use a 1.1 millimeter tool into the working channel. We're able to get these biopsies. Now, it must follow the track of the needle. It unfortunately does not make its own track. You need to already have made an established track. And the 5 to 6 second freeze obtains about a 2 millimeter sample. So it's a very useful tool, but it is a very costly tool. So it's something to think about using wisely as you design your programs. And with that, I'll turn this over to the next speaker. Thank you.
All right. Thank you, Ali. That was awesome. We'll save questions until the end. We should have about 20 minutes, I think, at the end for our panel discussion. And I'd like to introduce Dr. Joseph Cecenia. He's a staff physician at the Cleveland Clinic, current board member of the American Association of Bronchology and Interventional Pulmonology. And I was joking with him earlier, and he thought I wasn't going to do it, but he is the grand poobah of lung nodules. So he's been doing this for a long time, and I think probably has experienced every platform that's been out there for this. And so, Joe, take it away.
All right. Well, thanks, Otis. The Grand Pumbaa, I like that. I did think you were joking, but then here we are. So I'm going to talk about certain things that we could do with the robot as far as it pertains to lung cancer, and specifically, we'll talk a little bit about ablation. If we have time, we'll talk about injections and fiducials, or as I kind of subtitled here, the really cool things I could do with the robotic bronchoscope. So there's been a constant search for lobectomy alternatives for many, many years: SBRT, ablation, now PEF, pulse electrical field, intratumoral therapy, and sublobar resections. I'm not going to talk too much about SBRT, but we do know that SBRT is not perfect, although the radiation oncologists want to sell it that way. We all know that there's local failure, regional failure, and we also know that there's a risk of pneumonitis, some of which actually could be quite severe and debilitating. Ablation has been forever an alternative to SBRT, not really used as much because it's not as easy to use as SBRT, and it certainly has more side effects. Initially, it was radio frequency. Now we're moving into microwave ablation. Traditionally, this has been, like I said, been performed percutaneously, and it just relies on generation of heat through targeted energy delivery to tissues. And they actually, the people who ablate actually call it cooking tumors. RFA and NWA, they differ slightly in how the energy is delivered, what type of energy is delivered in an ablation zone, which I'm not going to get too much into. But they certainly differ in the amount of adverse events that are associated with each. Here's a typical ablation, and this is courtesy of Mike Pritchett, who probably has done more ablation procedures transbronchially than anyone in the U.S. and actually probably could be given this talk. The rate probably wasn't high enough for Mike, although the rate's 0, so we're doing this for free. Not saying that Mike is like that, but a lot of the stuff you're going to see is coming from Mike. And here's an example of a pre-ablation nodule. It was a tumor. After a month, you could see this little ablation zone or ablation effect around the tumor. And over time, the tumor or the nodule actually kind of shrinks. And you could see with PET scanning, you can see pre-ablation, PET avid, and then post-ablation, even though it's still there, cold on PET. There have been several studies regarding SBRT, comparing thermal ablation to SBRT. This is a large study looking at over almost 30,000 patients, and regarding overall survival, thermal ablation was not inferior to SBRT for primary treatment of stage 1 non-small cell, so we know it works. Another large meta-analysis, 40 different studies, 40 different trials, almost looking at 26, almost 2,700 thermal ablation patients versus, studies versus 215 SBRTs. So lots of patients. And this also showed that there were comparable outcomes after SBRT and microwave ablation, slightly better than RFA. But really, the biggest problem here with percutaneous ablation is that there's a risk of pneumothorax and BP fistula. The reason for this is that as you send out your catheter, your ablation catheter, and heat up that catheter, heat up an ablation zone around that tumor, sometimes the heat could extend away down the length of that probe, and the heat could actually heat up the pleura. Put a big hole in the pleura, and there's your pneumothorax. And if the other end of your probe is attached to or goes near a bronchus, you could actually create a bronchopleural fistula, which are very, very, very hard to treat, and they rarely heal. In addition to the pneumothorax and BP fistula, there's been reports of hemothorax, and there's also limited access to some nodules, which you just can't get a probe to. Here's a perfect example of a pneumothorax post-ablation. So let's talk a little bit about the transbronchial route. So moving from PERC to endobronchial, since we're not crossing the pleural space, the idea is that you'll get less pneumothorax and less BP fistula, and you'll have better access to challenging nodules in challenging regions. Don't worry so much about shifting from RF to MWA for the purpose of this talk. It's just that microwave ablation compared to RF gives a larger ablation zone and an ablation zone that's more predictable. And you want predictability because you want to make sure that your ablation zone sort of encompasses the nodule. The challenges, though, are if you're going to go to a transbronchial route, is that you kind of need to get really into the center of the nodule, or as close to it as possible. And this is hard to do with some of the catheter-based ENB technologies. So really what you sort of need to get out to this thing using whether you use shape sensing or ENB, but you really need to place the catheter in precise locations. And really you can only do this with robotic articulation. And then in addition to that, yeah, you want to be out there, but we want to make sure we're really out there. You want to confirm that radiographically. So most of these studies or most of these procedures are being done with cone beam CT, either fixed or mobile. And then there's some thought that this could be done with digital tomography, although this is still being worked out. The largest trial to date, if you can believe it, is out of the UK and Hong Kong. It's Calvin Eng and Kelvin Lau, who are two surgeons who do ablation, and 30 nodules, and they had very good local control. Their technical success was 100%, 1 month technique efficacy 100%, and they had very little adverse events. However, in the U.S., 2 trials are out there. The Flex 1, which is supposed to be the FDA mandated pivotal trial, which is stopped early after a death after only 11 patients. The Power study was done similar to Flex, new wave probe with the Monarch robot, again stopped early due to a death. The Flex 1 trial was stopped, like I said, never restarted. The Power study there's an attempt to revive that right now, but instead of being a pivotal trial, it's now being rebranded as and repurposed as a safety trial. Here's a perfect example of a bronchoscopic microwave ablation gone wrong. You can see here that there's just a huge cavity within the lung. There was some bleeding here involved, and so this is still in its infancy. The ablation is approved in the UK, Europe, and China. There's various clinical trials and user experiences with several companies that are going on right now outside of the US. Most of the work is being done in China and in the UK right now with several companies, New Wave, MDT, Creo, Endowave, and a lot of these companies, Creo and Endowave, they're not even planning on working in the US because the barrier to get FDA clearance is thought to be so high. What are the gaps of eventually doing this? Well, you kind of need to do it with cone beam CT or some equivalent, and access to these symptoms and to these systems is challenging. Not everyone has access to cone beam, and to get access is, like I said, very challenging. Gaps in the software, so whether or not your cone beam has augmented fluoroscopy, which can help you with this. The choice of system and each individual system's compatibility with robotics is still being worked out. Clearly, there's a physician skill and training component, which will really be limited to those with very strong bronchoscopic skills and ability, really to think critically in case the case doesn't go according to plan. And you need a stable and precise platform, something that could really deliver you there. Obviously, the robotics is certainly made for this, but we still have a long way to go before we to get there. So, kind of to summarize ablation, I think it's been shown that in select patients who are surgically contraindicated or have significant comorbid conditions similar to SBRT, microwave ablation may be feasible and a safe technique, a one-time treatment instead of 5 SBRT treatments for early stage lung cancers, metastases, highly suspicious lung nodules. It certainly has fewer pleural-based complications when compared to the percutaneous approach. So if we are going to go down this route, it's probably a good route to go down. But like I said, trials are still undergoing in the US, and it's still probably a long ways away. Let's look at other things in the last few minutes we have of this. PEF is something that seems to be promising. This is a non-thermal sort of alternative. What PEF is there's this high voltage, high frequency electronic pulses that are created using an antenna and a grounding pad that creates a low energy electric field. This electric field does is it destabilizes cell membranes, and it causes loss of cellular homeostasis, and cells die a few days later via programmed cell death mechanisms. The good thing about this, or one of the benefits of this, is thought to be that it preserves extracellular matrix and surrounding tissue. So unlike ablation, which just cooks things and vaporizes things, here you have preserved matrix and surrounding tissue, which makes it safe for critical structures. And it's thought to perhaps this release of extracellular matrix and tumor antigens might instigate or enhance an immune response towards the tumor. Here's the first transbronchial PF case in the United States, done by Mike Pritchett out in North Carolina. And you can see this was a metastatic renal, I believe. He was treated, and there 6 months later, you can see that this shrunk. Here's this effect that we talked about. Here is a case. This is from Joe Whitlark, who's now at Robert Wood in New Jersey. This was a metastatic sarcoma in a kid. This was treated. PEF was applied in a thigh lesion, and you could see several weeks later that all the other sites of tumor just shrunk without treatment. This kind of feeds this idea of this is called an abscopal effect, where you get release of tumor antigen. There's a host versus tumor response. Some immunologic mechanism has occurred, and now the body's working on tumor in other sites. Now, we don't see this in every case, but this is super, super intriguing. PEF doesn't work in all cases. This is the NYU percutaneous experience. There was progressive disease in 10% of their cohort, a partial response in 20, and stable disease in 70. So it certainly doesn't work in everyone. So there's a lot to work out. There's the Affinity trial, which is going on right now. This is a transbronchial PEF study. It's in process. There's, I think, the first 5 sites launched, and now they're ready to expand to more sites. So more follow-up coming. Future directions with PEF really is the green box on the right. Is can we get immune stimulation by incurring cell death in a way that's more kinder and gentler than just cooking something and vaporizing it? And there's some ideas of adding an adjunctive, immunotherapy to aid in the host versus tumor response. So we'll see where all this goes. It's a little bit of a ways away. Intratumoral therapy is another type of alternative that's out there that's kind of getting off the ground. This is really being supported by big pharma, as you might expect. This is really just direct injection of chemotherapy, not unlike what we do in other tumors, but we just haven't had the ability to do that before. Really, the leader in this, the trailblazer in this, is Matt Kinsey. This is his slide out of the University of Vermont, where he's just injecting these tumors using a robot and cone beam CT with cisplatin, and incurring tumor necrosis. This is a treatment resection study, and found that he had pretty good tumor response when doing this. Again, super, super early, but backed by a lot of big pharma money. Right, because big pharma makes no money on stage ones that you guys do, or that we might do with ablation, but they certainly could cash in on injecting their chemotherapy into these or whatever into these agents. And the last thing we'll talk about is sublobar resections, which surgeons already do, and they don't necessarily need our help, except in those nodules that are kind of difficult for them to palpate during the procedure, or GGOs, things that you really can't palpate at all. There's a lot of different things that have been out there for a while. Dye injection was certainly one, but there's been some issues with dispersal of the dye and how long the dye lasts for. So timing of the dye injection plus the surgery, is somewhat problematic unless you could do it all in one sitting. Like I know, Ali does these mark the tumor, resect all in the same sitting. Coils, you can just put coils in, but then how do you find them? Do you have to bring a C-arm in? But I think what's really coming to prominence right now are these dye soap coils. So what you do is you have these coils that have like these little sort of hairs on them. They're just these are just regular coils that you find in your IR department. You soak them in ICG for about 10 minutes, and then you, using your robotic scope, get them as close to or within the tumor as possible. Here's a nice example from Ganesh Krishnan's group out in California. And then when you go in to resect, you could see very clearly under fluorescent light that green dye, which is really just the result of the ICG in that coil just kind of migrating out into the surrounding lung tissue. Makes things super, super easy for a surgeon to find. You don't have to bring in a big fluoroscope to do this. And the other great thing about this is this ICG seems to be stable for up to a week to 10 days. So it doesn't really affect timing as much as like the other dyes that we use. So in summary, there's promise for robotic bronchoscopy with image integration to kind of move the field forward for inoperable and high comorbidity lung cancers. Ablation, I think in the US at least, is still years away. There's some promise of PEF, still years away. More studies need to be done. Intratumoral injections, again, backed by that money, also years away. These ICG impregnated coils are here now and they appear to offer advantages in the OR for lung sparing resections. And I think the overall summary is your jobs are safe. So I don't think anyone's coming in and ablating away your resection. So I'll stop there. Thank you, everyone.
All right, thanks, Joe. We'll hold questions to the end, and that's just a reminder to put your questions into the chat or into the Q&A, and I'll turn it over to you, John.
Thanks. Those were two great talks. It is my great pleasure to introduce my good friend, Luis Herrera. He's medical director of the Rod Taylor Thoracic Care Center at Orlando Health Cancer Institute. I look forward to your talk, Luis. Thank you for participating.
Thank you, John. Thank you, Otis and the STS for inviting me. I'll start sharing my slides here. It's an honor to be here with all of you and learn along this journey. My talk was basically about financial considerations, particularly around single anesthesia events. These are events where, as was mentioned before, we can do an ion and, a robotic bronchoscopy, in our case is ion, and the resection in the same anesthesia setting, basically combining the diagnosis and the treatment. So my disclosures. So as we all know, there's variations on the cancer care or the lung nodule care pathway today, depending on the institution, the patient, the referring providers, and such. But we do know that there's suboptimal delays in the time it takes to get a patient diagnosed and eventually treated. It's not unusual for a patient to have not just one, but on average nationally is 2.1 biopsies to achieve a diagnosis, to then stage and then treat the patient. So this sequential processing can lead to some delays. So I wanted to look as a program in collaboration with Ali, who works with me, and the rest of the team, is to create a more coordinated pathway where we can foresee not only how we're going to diagnose the patient, but how we're going to treat the patient, and use all the technologies at hand to try to shorten that time interval from diagnosis to treatment. Of course, there's financial implications of this, not only from the technology you choose to use, but also how you combine it, where it actually could be a financial detriment to some degree. But the question is it beneficial to the patient to justify that revenue loss? So that's what we're going to talk about in this brief talk. Is going to be brief, so we'll have some time for discussion and to enjoy the last presentation. So this is how we use robotic bronchoscopy. Is different scenarios, but in general, we have two sites of care. One is the endoscopy suite, which is basically outpatient procedures, mostly by our interventional pulmonologists in our group, one of which is Dr. Jiwani. And basically, it's primarily for lung nodule diagnosis. in the era of immunotherapy is very important nowadays to have a tissue diagnosis up front, especially for tumors that could be candidate for multimodality therapy. And also very often, almost universally, we combine the opportunity to stage the mediastinum properly, so the patient is then properly staged and treatment plan accurately achieved. And then the other scenario is in the operating room, where we do combined bronchoscopy and surgical approach for intraoperative diagnostics. But more commonly, as was mentioned, is localization with fiducial markers or ICG. And this is the focus of the talk today. But the question of who should go down the path of a combined procedure, that's always very controversial. How do you make sure that you don't have an inefficient day where you perform the bronchoscopy and decide not to proceed with surgery after you block out your day? And more importantly, how do you make this work from a financial perspective? So my approach on how to deal with the lung mass has changed a lot since we've had robotic bronchoscopy available. In the past, I found myself going to the OR and do diagnostic resections, whether that was a wedge followed by a lobectomy or whether that was a diagnostic segmentectomy. I would stage the mediastinum selectively. And one of the caveats is the fact that many of the lesions that we're dealing with in our era of lung cancer screening and incidental nodules are very small, non-palpable, and more so with robotic technology, can be difficult to feel or accurately detect where these ground glass nodules are. So with that thinking and that problem at hand, one of the clear indications of choosing a robotic bronchoscopy single anesthesia event is localization. Can we palpate these lesions reliably? Or should we employ the help of our colleagues to get this done? This is an example of a typical case of a single anesthesia event. Is right upper lobe biopsy-proven adenocarcinoma with a negative mediastinum. But upon closer review, you have two additional ground glass nodules in the same side. So we've become more aggressive in pursuing or managing secondary multifocal disease. Of course, you could argue that in the past, many of these would be observed as many patients have more than what meets the eye, and many have bilateral multifocal disease. But in our view, if you can simply not only diagnose these additional nodules, but potentially achieve local control at an early point, it could avoid return to the OR and a more difficult reoperation or worse off progression of disease. So this patient had a right upper lobectomy, fiducial markers of the middle lobe and the lower lobe GGOs, which were both different primary tumors, adenocarcinomas. So the advantages of a single anesthesia event are the ability to detect non-palpable lesions, as we discussed. This can decrease time in the OR that we waste trying to find the lesion. It also can avoid the dreaded missing the target, where you resect the specimen or the target, and you can't find it, the pathologist can't find it, and now you're second-guessing yourself that perhaps you left the lesion behind, or you have positive margins, and forces you to do a larger resection. It improves patients' throughput and satisfaction as they save steps to achieve a diagnosis and treatment, and also lowers the overall cost of care from a payer or patient perspective. It allows you to mark or localize nodules that are in between segments if you want to pursue more complex segmentectomies, or if the lesion is between segments. And also, as I mentioned, tackling multifocal ipsilateral small lesions. So as you know, there's a cost inherent to this robotic bronchoscopy procedures. This is the cost per case of a typical robotic bronchoscopy. In this case is for the ion system. It's about $1,800 per case, because the catheter is disposable after 5 lives, and there's a total cost for the box. or for each catheter. Then there's the vision probe, which also has a 5-life span. And then you have different catheter guides and connection cleaners that have certain lives as well. So in addition to your tools that you choose to use, that amounts to that average cost per case. Of course, each institution may have different vendor pricing, but this is the ballpark cost of direct supplies. But when you look at when you do our lung resections on average based on your payer mix, and this is a distribution of about 57% Medicare and 26% commercial, our administrators are satisfied with our contribution margin per robotic case. In this slide, it shows without using the ion, we have a contribution margin on average about $11,000 per case. It's on an XI system with robotic stapling, and the average net revenue per case of $26,000. And that's heavily influenced by your payer, of course, and the case complexity and length of stay. When you do use ion together with the lobectomy, you'll see that the contribution margin is a little bit higher, as you can charge for additional resources and codes for $14,800 per case. And that's a contribution margin that is fairly standard across our data. If you were to separate these out as two separate events, meaning the bronchoscopy first and then the resection, you'll see that the contribution margin would be a little bit higher as you have two episodes of revenue. One would be about $4,800 per individual ion case and the endosuite, plus another $11,000 per the separate event of the robotic surgery, for a total of $16,000. If you were to combine it, that drops down to about $14,800. So the difference is about $1,200. So yes, it is less cost beneficial or revenue beneficial as it erodes your contribution margin if you combine it, but we feel that what you save in patient satisfaction, in time gained by combining the procedure, is worth it for our patients. So to conclude, we believe that combining this diagnosis and treatment in the same anesthesia episode is feasible. It is still is still beneficial to the institution from a financial perspective and still profitable with a lower overall cost of care. But it's critical that you pick patients that are appropriate for such approach. You want to pick patients that have a high likelihood of malignancy in the target lesion. You pick patients that you want to resect regardless of whether the biopsy is diagnostic or inconclusive. So these are the type of patients that are driven to have a definitive answer and want the nodule resected, even if the biopsy is non-diagnostic or non-malignant, for their peace of mind. But we're still, it's an individualized decision and a conversation that we have with each patient to see which one fits the criteria or for a combined event. Thank you again to the STS organizing committee, John and Otis. Happy to take any questions in the panel discussion.
Luis, that was fantastic. And I do think this is something that touches on finances, that affects both IP and thoracic. So with that being said, I'm going to introduce someone I've introduced before, and she just is a rising star. So Dr. Erin Gillespie is now associate professor with tenure and chief of thoracic surgery, finally, at Creighton University. So it gives me a lot of joy to introduce you, and I look forward to your talk.
Awesome. Thank you so much. Thank you, Otis. Thank you, John, for having me. Thank you to the STS. It's such a pleasure to be here. Let's dive right in. Let's talk about sublobar resections. These are my disclosures. So we all know we're living in this very exciting new era of lung cancer. We have all these extraordinary treatments coming out. And really, with the NLST, we are seeing a stage shift. So we're diagnosing patients earlier and earlier. We're finding not only smaller nodules, but we're finding more and more of these subsolid nodules. I think everybody's pretty familiar with the CALGB 140503 trial, but you really can't, I think, talk about sublobar resections without mentioning it briefly. And so just as a reminder, this was an amazing randomized controlled trial that randomized patients with tumors that were 2 centimeters or less to lobar versus sublobar resections with negative lymph nodes. Importantly, I looked at the time of surgery. And what they found was that the disease-free survival was non-inferior for the sublobar resection arm. So they followed these patients out a long time, and at 5 years, we have a similar disease-free survival between the two groups. Similar trials performed over in Japan, our JCOG 0802 trial, and really between the two of these, we usher in this new era of sublobar resections, including segmental resections. And I'm going to talk a little bit about wedges, but I'm going to focus more on segmental resections today, because I think that's where we really have a lot of unique and exciting opportunities when we're thinking about navigational bronchoscopy. So let's talk a little bit about segments first. And I think we can all agree that there are some very simple segments and there are some more complex segments. So when I think about this, the simple segments, it's, our superior or S6 segmentectomies of our lower lobes, really bilaterally. And then I think about some of our upper divisions, and so our lingular resections, our apical, bi or tri-segmentectomies, really being sort of easier, more favorable. The anatomy really lays itself out beautifully for those. But we also have more complex ones. And so when we're thinking about some of the individual segmentectomies of a right upper lobe, some of our complex basilar segmentectomies as well. And I think really here there's a lot of richness and opportunities to help ourselves to make the resections much more feasible and really give ourselves some surgical breadcrumbs. So this is sort of a stolen remark from one of my residents. He was looking at the lung when we were doing our first complex segmentectomy together, and he said, "Are the landmarks that you're looking at definitive, or are they imaginary? Because I sure can't see them." And gosh, I think we all probably wish that a patient's lung actually looked like this image over towards the left side. But the reality is we have beautiful lobar anatomy, right? We can really often see our major and minor fissures on the right, our major fissure on the left, but it can be more complicated when we're trying to find some of these smaller segments. So what are some of the opportunities that we have? Well, certainly there's opportunities to localize the lesion itself, and we'll talk about a couple of the different ways that can be done. There's also ways to mark our anatomic boundaries and to mark our margins. So let's talk a little bit about localization. And so you've heard some of the ways that we can do that. Certainly you can use ICG, you can use methylene blue, and you can use coils. Now, one of the things that I think adds a lot of richness is really working in concert with your bronchoscopist, your interventional pulmonologist, whoever is helping you with these procedures, or if you're doing it yourself, really thinking about where you want to leave your marks to be able to help identify the site. I was lucky enough to be trained by Dr. Rickman to do robotic bronchoscopy. And one of the things that we talked a lot about, especially with the ground glass opacities, is there's a lot of richness because you can't really palpate those at all robotically, to giving yourself a couple of different sites of localization. So you absolutely can inject directly into the lesion itself, but not all lesions, as we know, are right at the surface of the lung. And while you do see some diffusion of the methylene blue in the ICG, it doesn't happen very quickly, especially if you're doing it at the same time as your surgical procedure. And so going all the way out to the pleura to leave yourself a little bit of dye to really help mark your location at the closest sort of pleural border. And then I actually like to drop a little bit of dye also at my most proximal extent of my lesion, because that really allows me to see the distal extent. So, it's kind of my localization on the pleura itself, my most proximal extent. So if I've taken out all the dye, I know that I've taken out that lesion. And so for something like this, that can be a really nice opportunity. So we have a ground glass opacity here with a little solid component. And so you can come right out to the pleura here and drop a little bit of dye. And you can also drop a little bit at the proximal area. That can be really helpful for your wedge resections, or even for complex segmentectomies, to really make sure you're getting the entirety of the lesion that you're looking to get. You can also localize multiple lesions in one or multiple lobes. And so here we had a patient with 2 nodules that were right adjacent to one another. And so we dropped 2 different dye loads within the lung itself. You can see here they merged a little bit in the middle. We're stapling around that. This was performed as a wedge resection for sublobar for 2 very small early stage adenocarcinomas. And so really it can help to guide your margins in a very, very rich way. So localizing and guiding margins, which I think is really nice. As you heard described, there's also an opportunity to drop coils within the lungs themselves. One of the rich parts about this is you can do the 2 procedures at separate settings. The dye-soaked coils, you usually soak them for about 10 minutes. They light up really nicely in the lungs for 0 to 9 days, and it may even surpass that as well. The added benefit of having a coil in the lung is no matter what approach you're using, whether you're digitally palpating the lung or if you're using the robot, actually just massaging over the surface of that lung, you can actually see the small bump where that coil is sitting to really help not only localize with the ICG itself, but also localize with the tactile sensation. And so here you can see that ICG lighting up beautifully and a sublobar resection being performed. Now, what is some of the other unique opportunities? Well, to me, especially for any sort of earlier career surgeons who are thinking about starting to do more complex segmentectomies, if you haven't had a lot of exposure to those in the past, you can leave yourself what I call surgical breadcrumbs. So in addition to leaving some dye at the pleural surface, at the proximal border of your lesion itself, you can also drop a tiny little bit of dye in your airway. So here you can see that we dropped just a little bit of dye in our airway here, lit it up beautifully. And so my fellow who's performing his first segmental resection can see the airway lit up beautifully. It can help to guide dissection and help to really get you through that case. And similarly, you can actually mark your boundaries. So if you'd rather not mark your lesion and just mark your anatomic boundaries of your segment, you can do that. And so you can actually use the navigational technology to localize the boundaries of your segment based on your arterial, venous, and airway anatomy. And you can leave multiple sites of dye along that border so you can actually have that as your markers as you're going in to do your dissection. So a lot of really rich opportunities to help not only guide the location of your lesion itself, but also guide the extent of resection and how you're going to perform that. Here you can see our little lesion that we have in our posterior segment of our right upper lobe. This was another lesion that we not only marked, but we left a little bit of dye within that airway to be able to help give ourselves a beautiful localization as well as a guide to help with the resection. I cannot emphasize enough that working in concert with a team is immeasurably helpful, not only because you have a partner who's going to be able to help you kind of drop a coil early if you're going to do 2 separate procedures, but also for training. And so for me, one of the richest relationships that I've had is with some of my IP colleagues who not only have helped in the operating room with diagnostic and localization, but also helped to train me in navigational bronchoscopy so that I'd be able to help take that to my new institution and sort of really expand the surgical opportunities for our team. So how do we think about doing these in the same day? And that's a question that I get asked a lot because everybody's really worried about adding a lot of time onto cases. And I can tell you that we really set ourselves up intentionally for success because we do a lot of same day localizations. We localize at the beginning of the case and then go on to have our resection. I always try to make this our first case of the day because that actually allows us to set up everything the night before. And I think that can really enhance efficiency. I plan my case during the induction of anesthesia. There's always plenty of time to do that. We put in a single lumen tube to start. I know there are some people who are actually doing this now through double lumens in lateral decubitus position. I still like to do it supine. Put in a single lumen tube, really clean out those airways, make sure I'm starting out with really nicely inflated lungs. Make sure you get that PEEP up, really ventilate your patient at the beginning, perform a flexible bronchoscopy, and then I do my robotic bronchoscopy with localization. We switch out to a double lumen tube, position and resect. And I can tell you that this on average for our team only adds about 7 minutes to the case. So we really aren't adding a significant burden to anybody. We're able to then take the robot bronchoscope out of the operating room. We send it over to the IP team so that they can get their day started as well. And so I think we can add certainly a lot of richness to our cases and really streamline it in an effective way. So in summary, I think the really robotic bronchoscopy, navigational bronchoscopy is incredibly useful for subsolid lesions for localization to help you define them. For small lesions in addition, I think it's wonderful helping to denote anatomic boundaries, especially for people who are learning to do these more complex segmentectomies. I think it's great for really identifying that critical anatomy. So even leaving a little bit of dye in the airway and enhancing completeness of resection. It's always great to have that complete resection the first time you go. And so always thinking about dropping that little bit of extra dye at the proximal extent, I think gives a lot of confidence in knowing that you've gotten everything that you've set out to get. And with that, I'll turn everything back over to our incredible hosts for the panel discussion.
Great talk from everybody. Really rich. We have about 10 minutes left for Q&A. We have a question in the Q&A, but I'm going to drop my first question, which is to Aaron and Otis, since I know this is, the Padawan and the master.
Aaron's the master.
Yes. We know that segments are defined by the airways, not by the blood supply. So how long have you guys been doing the airway marking? Because I don't think people are talking about that a lot. And as surgeons, when we're sitting there, the vessels are very easy to find. But, as you and I have seen, Otis, a lot of these right upper lobes suddenly get a left upper lobe anatomy where S1 and S2 are fused, and you end up dissecting quite a bit down there. So can you talk through that point in how you figured that out and how that's helped you?
Yeah, absolutely. So actually, it was sort of born out of the fact that I do a lot of teaching and really helping to coach the residents through these cases. I thought, what can I do to help set them up for the best success possible? So we really, as we started sort of planning through how we were going to transition our program to a much more sublobar program, sort of in the advent and in the aftermath of the CalGB 140503, I really didn't want to take any educational opportunities away from the fellows. And so really thinking through how I could help them to understand the anatomy in the richest way. And so I started out drawing pictures for them. But really what it came down to was how can I help them to localize that airway in the most effective fashion? And I thought, gosh, what if I left a little dye behind? Would that work? And so I actually started it out with some of the simple segmentectomies. And so I tried it in a superior segmental for a right lower lobe. It worked brilliantly. I tried it for then a lingular segmentectomy on the left side. And I thought, gosh, this is really going to work well. So the third case that I did it was for an apical segmentectomy on right upper lobe, and it worked brilliantly. And the key thing is you can't put a lot in there. Really, it is just the tiniest amount of dye that you're putting into that airway, because if not, it's gonna leach back and it's actually gonna light up your entire windpipe. And so we're talking like 0.1 mLs just to highlight really, and I leave it in sort of the distal extent of that segmental airway, knowing that it'll backtrack just a little bit and light it up. But so far we've had really incredible success with that.
Great. There's a question in the Q&A. Otis, do you want to read that, or do you want me to go ahead and address that?
Let's see here. So I've got, I see two. We'll do the first one. Regarding the single anesthesia event, please clarify the advantage of robotic bronchoscopy if resecting regardless of the biopsy results.
Probably for Luis.
Yeah, I'm happy to take that. So basically, these are patients who the purpose would be localization, right? So as Erin mentioned, that's the goal, right? If you're doing a single anesthesia event for diagnosis, okay, you have to be a little bit more careful. We do it sometimes. If we're going to localize and we don't have a diagnosis and we're doing a segment, for example, and it's a wedgeable lesion, I'd rather know, right? Because if you have a patient that you're gonna do a combining case, like I mentioned, it's ideal for that patient that you want to take this out regardless. The only exception would be a diagnosis of granulomatous disease in the intraoperative sample. And it depends if you live in a high granulomatous region like you guys do in Nashville. So in that region, I'll be very cautious about this, especially if you're gonna back out if you get granulomas on the biopsy, right? So those cases, those lesions that look perhaps very hard on PET and solid, in a high granulomatous region, you may not want to do. But we're talking about a GGO or a mixed GGO that it's a high likelihood is going to be an early stage adeno potentially. Those are the kind of cases that you do. The diagnosis can help me perhaps know if I wedge this or if I do a segment. Do I go straight to a lobectomy? I'd rather not do diagnostic lobectomy, but I have no problem doing a diagnostic segmentectomy if I get a non-answer on the needle.
So I'm going to go, that was a great answer. I'm going to go to the next question, which actually Otis and I have been discussing recently, which is from Sanchez Soto. Great talks. I would like to go deeper on ICG nodule marking. Which is the best technique to avoid spreading in the lung tissue? Thanks. And for what Otis and I found was we want to do a biopsy. We want to know what it is. And then he's leaving, dye for me. But obviously you're distorting the planes. And when then you start manipulating that tissue as a surgeon, you start spreading that dye out. And I mean, it's fine if you're going to be doing a lobe, but most of us are trying to do either a segment or a sublobar resection. So maybe either Joe or Ali or both of you and Otis can kind of jump in and answer that question.
I think that the reason that we use, our surgeons like to use the ICG coils is it's more of a thing of timing. So if I wanted to use dye, I have a limited finite, the coordination becomes very difficult. So if I put in dye, the surgeon doesn't have much time to go to the OR and take that out. If I put in a coil, if the surgeon tells me I'm resecting next Thursday at 2 o'clock, I know that I have a week to 10 days to get my bronch in and settled and the coil in. So it gives us more leeway. The coil also, if I place it robotically with image guidance, I know I'm getting it exactly where it needs to be, which is either in the nodule or adjacent to the nodule. So where he sees that little area of ICG is exactly where they need to be. As Aaron said, if you overdo it with the dye just a little bit, I've early on in my career, I had a very angry call from a very angry surgeon who said, do you want me to take out the whole lung? Because that's where the dye is everywhere. So, we've learned from that, obviously, but I think that the ICG it's a slick procedure, and it's so easy to see. They just shine a light, and then you saw the photos. There it is. So I don't think one or the other is any better. I think you have less leakage, obviously, with the ICG because it's just on that little tornado coil. I don't know if anybody thinks any differently.
Yeah, so
I think to
I
follow
think
that up
we've done a
with,
lot of. Oh, sorry. We've done a lot of work back and forth, and Luis can tell you the stories of all the different trials and tribulations we had of trying to figure out the best protocol for us. For us, it's all about marking that segment in the end, right? So they know exactly where they're going, recognizing as well that the deeper you are in the lung, the less likely they're going to visualize that. And you really only have the last 2 centimeters you can put anything. And so through those trials and tribulations and testing, we've come up with a protocol that seems to work very well for us, especially, which is to do a 1 cc of ICG green undiluted 1 centimeter from the pleura. So if we have to go through the lesion, that's fine. If we're proximal to the lesion, that's fine. It doesn't matter. But we aim to be about 1 centimeter from the pleura. We don't prime, we don't flush. So in reality, only about 0.5 cc's actually gets through our needle into the lung. And Luis can probably tell you that gives him a very nice little marking that he can see, and it doesn't extravasate. We don't tend to see any issues. He can take his picture even an hour later, and he's got a nice thing. Now, we are blessed. We are able to do what is true single anesthesia pretty well. I don't get Aaron 7 minutes. Ours is probably about 15 minutes in and out the door, but it works out pretty well.
One of the other things to think about is one of the big things that causes that dye to spread is tissue manipulation. And so as a surgeon, the very first thing I do when I get into the operating room is I turn on my Firefly, I look at where my mark is, I mark the surface with electric cautery, and then I very minimally manipulate that part of the lung. You really don't have to mash on the lung very much when you're doing a segmentectomy and lobectomy. You ought not to. And so really being judicious with how you handle tissue is actually going to avoid a lot of spread as well.
And then one other thing that Ali mentioned was the cryoprobe and doing a biopsy. Like we're trying to get a diagnosis at the same time. We kind of learned this the hard way, is that cryoprobe is a big biopsy, causes bleeding around the nodule. And it may cause something that's palpable for you there, but it also disrupts tissue planes. And even if you just put a tiny bit of the ICG, it will spread throughout the lung, and it really makes it hard to localize because it gets into the blood vessels because it's bleeding around there, that sort of thing.
So Luis and Aaron, one last thought for you guys. OTL is coming out with a molecular marker that may make any kind of dyes or coils unnecessary, which is good for either metastatic disease or things that we're not expecting, which we all see in the operating room. Any thoughts on that?
Yeah, I think it's a promising technology. There's two agents. One is OTL, and the other one is VGT309. OTL is TTF1 receptor specific, so it only works for adeno. The other one is cathepsin invasive protein base targeting, so it's more generalized. So it works for metastatic disease, any type of malignancy. But the problem with that technology is you're limited to surface tumors. If the tumor is too deep, you're not going to see the agent on near infrared. So there's still going to be a role for dye marking. I like the idea of Aaron's about airway localization, and I wonder if other dyes can come up, different colors, different wavelengths, or just different colors to avoid how it's not spreading from the parenchyma yet. It's a unique bronchial mark. So anyway, I think the future of localization is important. There's also RFID type markers where you can put an RFID chip on the lesion and then use sensors or probes to detect the signal. So there's clearly a clinical need to do this right. So more to come.
I think the other thing to remember, though, with a lot of these new technologies coming out is they use different wavelengths of light. And so it may also require that we change some of the technologies that we're using or incorporate new software into the technologies we're currently using to make sure that we can sort of leverage all of these new kind of alternative ways to localize as well. And genuinely, the two big concerns, I think, are one, the solidity of the nodule, because that's going to determine how much it fluoresces. So for some of the GGOs or subsolids, that can pose a little bit of challenge. And then depending on what surface marker you're leveraging, knowing what type of tumor you have is going to be critical, knowing what surface marker is potentially going to be there. Not all adenos, as we know, are highly expressive of TTF1. And so really it will demand a careful coordination with pathology as well to make sure that we're using those new markers really effectively too.
I'd also say that the cost of the marker is going to be an issue right now. That it costs as much as your surgery, so that'll need to come down.
Well, that part's not exactly true, but we can talk about that offline. Well, I want to thank all of our guests and our members for coming on. These were very engaging talks. We were hoping to have a little bit longer of a Q&A, but I think I learned so much from all of you. So I really want to thank all of you individually for taking the time. I want to take the opportunity to thank the STS and thank all of the people who came on this webinar tonight to listen to this. We will have a recording for you later next week. I know for me, this has been fantastic. So thank you so much.
Thank you. It's a pleasure.
Thanks, guys.
Pleasure. Thank you.
Good night.
Thank you so much to our moderators and panelists today for your participation and insight. We appreciate your time and efforts. Thank you. The STS Cardiothoracic Surgery ebook, the most authoritative online resource for CT surgical information, is an invaluable and constantly updated tool for surgeons, trainees, and the entire CT surgery team. Subscriptions can be accessed through the web or a convenient mobile app. Learn more at sts.org/ebook. Join us for the next STS webinar on Thursday, June 6th, Early Career Journey, Pathway to STS Involvement and Leadership. Details on sts.org. Thank you so much. Hope you all have a great night.